Everyone, thanks for joining us tonight. We're still going to give it a couple of minutes to make sure people log in, but we're having a presentation tonight on localized prostate cancer and PSA testing update by a consultant urologist, Dr. Diwei Lin. So we'll give it 60 more seconds and then we'll kick off. If you've got any questions along the way, just pop it in the chat, and Colin and I will be monitoring the chat and we'll interrupt as needed. So we'll give another 30 seconds. All right. Well, again, thank you for joining us. I'll pass you on and we'll start tonight's session.
All right. Thanks, Jared, for the introduction. So hi, everyone. Good evening. Thanks for coming. So my name is Diwei Lin. I'm a urologist based in Adelaide. I have my own practice up at Calvary North Adelaide Hospital. And just a quick introduction about myself. I go to quite a few places around Adelaide, and I'm based at Calvary North Adelaide, but I also go to Winter Gardens, down in Mount Barker, and up in Elizabethville, and do operate at most of the hospitals across Adelaide. So the topic of discussion tonight is about treatment of localized prostate cancer and some updates about PSA testing, which I know are very controversial, and we'll try to talk a little bit about that today, and I'm happy to take questions at the end. So this is a brief outline of what we're going to talk about, including the epidemiology of prostate cancer in Australia, the current PSA testing guidelines and recommendations. I'll acknowledge that these differ from some of the College of GP guidelines, and I'll tell you what I do in my practice and what the Urology Association also recommends. And then we'll talk briefly about some management options for localized prostate cancer, such as surveillance, watchful waiting, surgery, radiation, and a novel treatment approach called focal therapy, which we'll talk about very shortly. So just some numbers about prostate cancer. Prostate cancer is one of the most commonly diagnosed cancers in Australia, and it's now the most commonly diagnosed cancer in men. It's getting a lot of traction both in the media as well as in hospitals about how common it is, and patients are definitely becoming a lot more aware of prostate cancer and its prevalence in the population. A large number of men die from prostate cancer every year, and a lot of them do get diagnosed. Up to 24,000 men diagnosed with prostate cancer in 2022. So the question I often get from patients when they come with a raised PSA that a GP has done is, can the PSA be raised for any other reason, and why is it high? It can, and some of the other causes are inflammation of the prostate from prostatitis, catheterization, biopsy, and ejaculation. So the correct way to actually get a PSA test from a patient, if you counsel them properly, is you tell them to go back to the same place they usually have it done, avoid ejaculation and push bike riding for at least 48 hours before, and that often gives them a more accurate result. So if you do see subtle differences in your PSA testing, if you do it over a couple of months and you find that it goes up and down, often the reason is one of these other things that they haven't done. So, but I often tell them that the most common causes are BPH and prostate cancer. So the PSA testing guidelines that I'll discuss in the next couple of slides differ quite a lot from what the RACGP kind of recommendations for PSA testing is. But what I will talk about are these guidelines that have now been recommended and endorsed both by the Prostate Cancer Foundation, the Cancer Council, and also by the NHMRC. So, to go out on a limb, I'd say that the current GP college guidelines are probably due for some updates in light of these new recommendations, to bring it into line with what urologists across Australia and New Zealand are doing. So I've left a couple of links up here, both in this slide from the prostate. This is from the Prostate Cancer Foundation, and the next slide is from the Urologist Society. And we do acknowledge that there's a huge amount of controversy, and so many GPs that I speak with do say, that there's so much confusion about who to test, when to test, how to interpret those test results, when to refer, who to refer. So the Urology Society definitely recognizes this. There's a controversy with regards to testing, but we hope that by discussing what I will show you in the next couple of slides, that it will lead to improvement in patient outcomes while minimizing harm. So these are a couple of little snippets that I've taken off the guidelines about PSA testing, and the current guidelines are quite simple and have simplified things to avoid confusions in the past. So in the past, we used to look at things such as PSA velocity, PSA density, age-specific reference ranges. So you would look at a gentleman in his 50s and say, well, PSA of this is okay. And if you're 60, a PSA of that would be okay. Now we say for the average risk patient or the average risk men, you offer them PSA testing from the age of 50 to 69 every 2 years. And if their PSA is above 3, then you look into it further. So if their PSA is above 3, you repeat the PSA within 3 months with a 3 to total ratio. And if it's still elevated, then they need further investigation. There's a caveat there that says you have to inform them about the benefits and harms of PSA testing. And that really means that you need to tell them that if we test your PSA and it's high, it will lead on to potentially other tests, other investigations. You may need a biopsy, and there are often risks associated. Well, there can be risks associated with any further investigations. Look, I've never had a patient that I've offered testing to on the pretext of looking for prostate cancer who has actually come back and said, no, I'd rather not know and I'd rather not get tested. So I think you just need to counsel them that there are implications if your PSA is raised, that it will trigger further tests. It says for the average risk man, there's no low risk man for prostate cancer. So every man with no family history of prostate cancer is at average risk. If they have one family member with prostate cancer, their risk of prostate cancer increases by at least 2 times. If they have 2 family members, and these are immediate male family members, then their risk goes up by 3 to 5 times. And if they have 3 or more family members, their risk goes up by 11 times. So it is quite significant. So if, for example, they had a brother with prostate cancer, that puts their risk up, and you would start testing them at 45 instead of 50. And that comes onto that second box there, where we say for the men 45 to 69, whose risk of prostate cancer is double because he has 1 male immediate family relative, then you would test him earlier, and you would have a lower threshold for checking his PSA. Start looking at 2 instead of 3. And finally, for the patient, on the last slide, we talk about checking their PSA again within 3 months with a 3 to total ratio. And at that time, we look at whether the PSA remains elevated or whether the total ratio is less than 25%. And often that triggers the referral on to the specialist. So staying on that slide, there's a couple of other things I think that the questions I often get are, should I do a DRE? I know that a GP rate book says it's not required, and I do agree with that. The main reason being, and I get a lot of questions asked about why GPs are told not to do a DRE, and I think the rationale behind it is unless you do a lot of DREs or you are familiar with them, which some GPs who do a lot of men's health are, they feel that there is a potential for underdiagnosis or overdiagnosis. So you either do a DRE and you because you're not sure, you tell the patient, oh, there probably is something there, and that leads on to potentially unnecessary tests, or you miss something and subsequently the patient gets upset that something was missed on the DRE. So they have recommended that you don't do a DRE and just work on PSA alone. Look, it's not going to cover everything, and patients can have elevated or have a normal PSA and prostate cancer, and it's something many urologists do see. So there will be the odd patients that do slip through. So if there's any doubt at all, you often would want to get a specialist opinion, I think. So the reason why I think a lot of the PSA testing guidelines need updating is because we know that the data supporting PSA testing has come a long way from when the guidelines in Australia for GPs was first developed. The initial guidelines in Australia came about because the Americans did this big analysis. The Preventative Services Task Force looked at all these data, and they thought that PSA testing led to overdiagnosis and overtreatment without a meaningful impact on prostate cancer specific survival and patient outcomes. So they recommended that GPs in America in primary care stop doing PSA testing. As a result of that, they then looked at their data a couple of years later and found out that the number of men that actually were diagnosed with metastatic late-stage prostate cancer increased exponentially, and the rates of prostate cancer-specific death significantly increased. And quite quickly, they reversed their recommendations. That happened many years ago, at least 4 years ago now, and we haven't quite caught up in Australia. So the guidelines definitely need to be looked at again, I think. We have a lot of data now that supports that appropriately applied PSA testing does lead to increased survival benefit. And the things that we do now we've come a long way in the last 5 to 10 years with regards to PSA testing, prostate cancer diagnosis. MRIs, we now use MRI quite a lot for PSA testing. It's rebatable if it's ordered by a urologist or a specialist. So Medicare and MBS have really stepped up to the utilization of MRI to help localize or identify if there are lesions within the prostate. And as a result, we can sometimes reduce the number of biopsies that we eventually end up doing. So for a patient with a slightly elevated PSA with a normal DRE and a normal MRI, you could potentially delay their biopsy if their PSA remains static, for example. Some of the concerns about PSA testing leading on to unnecessary biopsies with a risk of biopsy-related sepsis have also decreased now that we're doing transperineal prostate biopsies in most parts of Australia. And that involves a completely different technique where we take a biopsy through the perineum and through the skin rather than transrectally through the rectum. And infection rates with a transperineal technique are significantly lower. So the morbidity associated with biopsy is much less. Finally, as well, in Australia, we do a lot of active surveillance, and we've become very good at developing robust guidelines about how to do active surveillance. And we see a lot of men with low-risk prostate cancer who now get put on surveillance rather than treatment with surgery or radiation, which reduces the rate of overtreatment and the associated treatment-related morbidity. You will see a lot of improvement in staging moving forward, such as PSMA PET scans, which is again a very new thing that Adelaide especially has been quite a leader in, and Australia in the world compared to the Americans and the Europeans. So a lot of the data with regards to PSMA PET scans, both in the staging and potentially in the future in the initial diagnosis of prostate cancer, is a big evolving area. So we'll talk a little bit about the surgical and radiation techniques that we've also evolved over the last 10 or 15 years that have limited the morbidity of both radiation, and with the advent of robotic surgery, we've decreased the morbidity associated with prostate surgery as well for prostate cancer. So just to talk a little bit about the tools that I often would use in the detection of prostate cancer, and these will be familiar to everybody listening in, but PSA. So I tell all my patients that when I first see them, I said, you need 4 things to either diagnose or confidently exclude clinically significant prostate cancer. And these 4 are a PSA, a DRE, an MRI, and a biopsy. So these are in order of, we progress in that order and in order of increasing morbidity. So one leads to another, and only if there's an indication to progress accordingly. So if you look at prostate cancer and how we manage prostate cancer in terms of localized disease, so this is prostate cancer that is confined to the prostate. It's a completely different topic if there's nodal involvement either in the pelvis or in the distant or in the bones or anywhere else outside. But If they have localized disease, which is confirmed on MRI scan and a subsequent PET scan or a bone scan, you can broadly break it down into three categories. So low risk, intermediate, and high risk prostate cancer. So low risk prostate cancer is Gleason 6 disease or grade group 1 prostate cancer. And broadly speaking, you would survey most of these patients. So the ones that you probably would not put on active surveillance would be the patient that could be very young. So it's somebody that would be on surveillance for a very long time. And surveillance often involves regular PSA testing, DREs, MRIs, and biopsies every few years. So while that might be okay for the patient in his late 60s or early 70s, for a patient in his early 50s, doing MRIs every 2 or 3 years with biopsies every 2 to 3 years till he's well into his 70s is quite an onerous experience for them. So in somebody like that, I would certainly offer them active surveillance, but I wouldn't deny them the option of having radical curative treatment. And with intermediate risk cancer, so these are Gleason 7 prostate cancers, we often offer them treatment, and treatment would be in the form of either a radical prostatectomy or radiation treatment, either with external beam radiation or brachytherapy. So in patients with intermediate risk prostate cancer, the reason we offer them treatment is because we know that within 10 years, their rates of cancer-specific mortality and the complications of prostate surgery are significantly higher than men with low-risk prostate cancer. Finally, in high-risk prostate cancer, it depends on the exact pathology that they have, but the treatment intent often is to cure, and that can either be done with surgery as part of multimodal therapy. So they have surgery and radiation in a way to, in a sense, to clean up whatever is still left in the pelvis. And we often delay that radiation depending on how their PSA changes after surgery. The other option especially for older men who want to avoid the morbidity of surgery, is to have radiation treatment. And we often do that in conjunction with hormonal therapy. And then down the bottom of the slide, you can see that line there that says we expect them to live at least 10 years before we consider any treatment for localized prostate cancer, because we know that prostate cancer is often a very slow growing disease. You want to make sure that you're doing the patient more good than harm by treating them. So to talk a little bit about active surveillance for prostate cancer, the goal of active surveillance, and what I tell my patients is active surveillance means exactly what it sounds like. It's surveillance, but active intervention and active management if anything changes. So it's not saying to the patient, you'll be fine, don't worry about it and leave it alone. It actually means that you're going to watch them very closely and you're going to change the plan if anything changes. In fact, when they actually looked at survival outcomes for patients on active surveillance, they found out that the patients actually live longer than patients of men in the general population. And that was because these patients who had prostate cancer, low-risk prostate cancer that were having surveillance, actually saw their doctors more often, saw their urologists, saw their GPs, ended up finding other things that then they got treated for and improved their overall morbidity, such as better diabetes control, hypertension. So they lived longer because they saw their GPs more regularly and then got looked after in terms of their general health. With regards to their prostate cancer, the goal of active surveillance is just to avoid causing treatment-related morbidity. We are quite specific about who is suitable for active surveillance, but you want to make sure it's somebody who is going to live at least 10 years, who, if you're going to change the plan and treat them, are actually a candidate for treatment. They need to have low-risk prostate cancer, and they actually need to be motivated. So you need to make sure, we make sure it's somebody who is compliant with treatment, who will come back for his regular PSA testing, who will come back for his regular MRIs every couple of years, and will be suitable for a biopsy. So, for example, somebody who lives in the country, miles away from everybody, and expecting him to come into the city every 6 to 12 months for tests or for MRI scan, or somebody who will be non-compliant, there'll be somebody who's not a great candidate for active surveillance. Some of the issues related to active surveillance are the biopsies that get done every couple of years, and that's to exclude an upstaging of disease. And with each procedure, there is the cost associated with logistics of coming in, having a procedure done, and the small but not insignificant risk of complications from having both surgery and an anesthetic. For all men who are on active surveillance, about a third of them actually eventually undergo treatment. And it's not just because they've an upstaging of their disease, but a lot of patients actually just get fed up with going on surveillance. They just get tired of having regular blood tests, DREs, and MRI scans and biopsy. So they just say, look, just get it over and done with and get it out. So that's one of the most common reasons actually why we take patients off active surveillance. These are some of the outcomes with active surveillance. So when patients often come, I say to them, and they all hear the saying that where we go, you die with it, not from it. And that's very true, but only for low risk prostate cancer patients on active surveillance. And in the graph, you can see, or in the table, you can see the 10-year overall survival for men on active surveillance. It's 98 to 100%, so it's extremely high. So 1 or 2 in 100 die from prostate cancer. Some of the triggers for treatment for men on active surveillance would be, it mainly is any upstaging of the disease. So the disease progresses in terms of its grade or in terms of its volume. And watchful waiting is another common thing that we would do as urologists. And this is really for the older patient where you don't expect them to live more than 10 years. And their goal here is not to cure the cancer, but to just limit the morbidity of treatment. The follow-up is not well defined for watchful waiting, and we often look at how their symptoms progress. You'll find a great difference amongst urologists in regards to when you watch them, how often you check their PSA, how often you see them, and when you treat them. So personally, my practice is to treat them only when their PSA is above 50 or when they become symptomatic. And the symptoms that I would watch for are worsening urinary function, hematuria, bone pain, or if they do develop metastatic disease. So surgery, radical prostatectomy has come a long way. We used to do these operations via an open technique, and that was often associated with a longer stay in hospital, more blood loss, and what we thought was surgical outcomes that weren't as good as doing it robotically with a robotic-assisted laparoscopic technique. We know that in surgeons that do a lot of open prostatectomies, their outcomes are similar to surgeons that do a robotic prostatectomy. But robotic prostatectomies now become increasingly popular, increasingly available. It's a procedure that, if done well, means that the patient can go home the next day, or they have a 1 or 2 night stay in hospital. We know they lose less blood, and their outcomes in terms of their functional outcomes with regards to erections and continence outcomes are comparable, if not better, than what we traditionally used to do. So there's a big change now, especially in South Australia and Adelaide, where we see a lot more robotic prostatectomies being done both in the public and the private sector. So the side effects of robotic prostatectomy is what I think a lot of doctors in primary care will see. The main things that I talk to patients about, besides the immediate perioperative outcomes and complications, are the longer term outcomes. And the 2 things that we do tell them all about are the rates of urinary incontinence, which is quite small. About 2% get severe incontinence, and that's defined by significant leakage of urine, more than 400 mils over 24 hours, beyond a year. We often see now with robotic prostatectomies that men regain their continence within weeks, if not months, rather than any longer than that. So it's an excellent way to achieve a good outcome for patients. With regards to the erections, it's a very varied number, because that number depends significantly on the initial pathology and other aspects such as what the MRI shows, where the disease is within the prostate, and surgeon experience and surgical technique. So that accounts for that very big variation. Some of the other things there are things that we tell all the patients about, because men do get quite particular about the shortening of the penis, which is something that we warn them all about, and a surprising number do get quite upset about afterwards. So. Radiation treatment is suitable for men of all age groups and all risk groups as well. We know that there are, so the question I often get at this stage is, is one better than the other? And the answer is no. The side effect profile differs quite significantly, but the survival outcomes, both with regards to radiation and surgery, are quite similar. So the complications of radiation treatment here are related to, as a lot of people here would know, they get quite similar complications. So they still get erectile dysfunction, they get issues with bladder irritation and incontinence, but these side effects often come much later down the track. So while we often think that in a 70 or 75-year-old patient, it may not matter if their complications from radiation catch up with them 10 or 15 years down the track when they're a lot older. But for the 60-year-old man, if you told him, if he had bad hemorrhagic cystitis, for example, which can present with intractable hematuria 10 or 15 years down the track, he's only in his 70s, which means that he's got a long life, a long way to go, putting up with these symptoms that are often not curable, just controllable. So as much as we say that the outcomes are quite similar, when they actually looked at it with a forest plot in a review, you see the little diamond down on the right side of the two graphs that do slightly favor surgery in terms of overall mortality and prostate cancer specific mortality. So there are some other considerations to think about when comparing surgery to radiation treatment, and these include the fact that when we do a radical prostatectomy, we know that the PSA, if we've cured them and there's nothing else outside of the prostate, becomes undetectable. So that makes PSA monitoring easy. You send off the PSA at 6 weeks and then every 3 months for the first year, and you see their PSA come back as less than 0.03 or undetectable. And you can tell the patient quite confidently that their PSA and their disease is gone. With radiation treatment, their PSA may not become undetectable because it can be benign prostate tissue that's left, and that benign prostate tissue continues to make PSA. So the PSA can remain present and can fluctuate. The sequencing of treatment means that if they have surgery and their PSA is still high, they can have radiation if there's a concern that there might be a positive margin or residual cancer. But doing it the other way is extremely difficult. So if they have radiation first and their PSA starts going up again afterwards, and there's residual disease within the prostate, doing what is called a salvage prostatectomy, which is removing the prostate after radiation, has significantly higher complications and is a much harder operation to do. So that's the other thing to think about. So one thing I do often tell my patients is the side effects as well. So it's work hard now or work hard later. So with surgery, the hardest part of surgery is the immediate post-operative period for the first couple of weeks, where they do pelvic floor exercises in an attempt to regain their continence quickly. So they have to put in the effort then. And once they regain full continence, usually within a couple of months, up to a year, then the hard work finishes. Whereas with radiation treatment, it's easy to get through the first part, but if they do get complications down the track, those complications become much harder to treat. And finally, at the end of the day as well, it really is about the patient. So if I have seen young patients who come and say, look, I can't take 6 weeks or 4 weeks off from work. I have to be on the move. I have to, I can't stop my life to get this treated. It doesn't happen often, but it does happen. And these patients often do end up going for radiation treatment instead, just because they can't afford to take time off for surgery. Something that's quite interesting that I will spend a couple of minutes talking about is focal therapy for prostate cancer. And while it's not something that's mainstream or that we're doing, it's a novel treatment approach for prostate cancer that I think in the next 5 to 10 years we'll see more evidence about, and potentially see it become more mainstream. You can see the machine on the left, and what it does is it's those little gray probes in the middle of the picture are probes that are inserted into the prostate under ultrasound guidance, and the machine generates an electrical current that goes between the probes. So the probes go in a quadrant of the prostate, and the current is delivered between the probes, and cancer is then killed by an electrical current and disruption of cell membranes without the use of heat or removal of any prostate tissue. It's a very novel way of treating prostate cancer. We know it works because when we check their PSA afterwards, it goes down. And it's the downsides of it is that we don't have long-term data yet. And we're still developing the guidelines with regards to who it's suitable for, how we use it, how we screen it. But it really is one of these techniques that I think it should be a watch this space in the years that come. So how I decide about how to treat prostate cancer. So the patient factors and disease factors. The patient factors that I look at is my personal cutoff is in general for men in his mid-70s. I do accept that some men, even older men who are very fit, the age is just a number for them, and I completely agree. So I do look at the patient in front of me. Patient preference is probably the most important thing here, and as you can imagine, the patient decides. So I always tell them that my job is not to tell them what to do, but to present them the options, the pros and cons of each, and help them make an informed decision. And that's probably the most significant part of patient factors. Continence and sexual function are very important to a lot of men, and does play a big factor in what they do decide to have. And finally, their comorbidities. So these are their cardiac respiratory status, whether they've had previous operations, and other complicating surgical factors. The disease factors mean that if they have pelvic nodes or lymph node involvement, that significantly alters what we do decide to give them, and the extent of disease both within and outside the prostate. So in a patient with locally advanced prostate cancer, they may be better off having radiation if they have nodal involvement, because the presumption is here that they have micrometastatic disease. So these are some of the things that I think about. In Adelaide, we have a lot more robotic access than we did 5 years ago, and most of the hospitals now have access to a robot, both in the public and the private, and that's also changed quite markedly in the last couple of years. So just putting up some clinical practice questions for people to think about, about how you check and test for PSA and test for prostate cancer. So some of the points to think about is, do you ask them about their family history prior to testing? And as we discussed, the family history makes a big difference in terms of their risk. It doesn't really matter on their maternal side, or if their second uncle had prostate cancer. It really is just the immediate male family members. It's important, I think, to discuss prostate cancer testing with men over 50 for the reasons that we've discussed. The diagnosis of prostate cancer, I hope this talk has clarified some of the things that at least as a urologist, I do in terms of testing PSA and what guidelines and what ranges to use. And with regards to DREs, MRI is the other thing I think we mentioned briefly at the start, and a urologist orders an MRI and it's MBS rebatable. So it is quite a big cost saving for patients in the appropriately ordered MRI, of course. Yeah, and finally, that last point we covered right at the start about the harms and benefits and harms of prostate cancer testing. So the other common thing I do get as well from a lot of patients who see me about PSA testing and prostate cancer is they say, well, I don't feel anything. I feel completely fine. Are you sure I've got prostate cancer? And what I often say to them is that prostate cancer, especially in its early stages, presents with no symptoms. By the time it gets to a symptomatic stage, either with hematuria or urinary retention or bone pain, often it's quite advanced or even metastatic. And in extreme circumstances, a patient, if you think especially in middle or old age men with back pain, as well as neurological symptoms in the lower limb associated with urinary symptoms, you certainly have to think about whether or not they have advanced metastatic prostate cancer. And if you check their PSA early, then you send them straight to hospital, often these patients. Yeah, and so that's the talk about prostate cancer and PSA testing.
That was great, Diwei. Thanks so much for your time tonight. You made a really interesting point. I read a news article recently about PSA testing and going to the same lab.
Yeah.
I don't know if you saw that article, but there was a doctor in Queensland and he sent his blood to 8 different labs and he got a spectrum of 2.6 to 3.6. And with the new recommendations of being greater than 3, seeing the urologist. It really shows the importance of sending those bloods to the same lab each time.
Yeah, absolutely.
Just to get the consistency. Yeah. Do you have any questions on the chat then?
No, just a comment. That was great. I have a question, and I don't know. I think often patients will come in and they want a rectal examination because they're expecting one, and you talk about it, but sometimes they actually still want to go ahead with it. But I was always told not to do that on the same day as the blood test.
Yeah.
Does DRE put your
it does put
PSA
the PSA up marginally, I think. Yeah. So I wouldn't do a DRE and then tell them to do a PSA test straight away. So I do a DRE in their rooms and I say to them, go and do a PSA blood test in a day or two. That's really all you know. Yeah.
And with the ejaculation, wait 48 hours?
48 hours. Push bikes and ejaculation.
Push bikes as well.
Push bikes as well. Yeah. It's the bumping on the perineum. Yeah, that causes. Well, yeah, they have looked into it and they think there is some association. So
yeah.
So sex and ejaculation and pushback riding 48 hours. Yeah. It really only makes a difference for the subtle changes. It's not, for the guy with a PSA of 10, it's no point telling him to avoid a pushback for 2 days. His PSA is not going to go to 5 because of that. So it's somebody with a fluctuating PSA that goes 3 to 4 to 3 to 4. It's not sure why.
Yeah.
You tell them to do it. Same lab, 48 hours, no pushback riding.
Yeah. Is there any Medicare rules on how many times you can order a PSA throughout a year?
Yes. In fact, the Medicare rules are, I think, they're a little bit more confusing now. I think so. The correct answer about PSA testing and the Medicare benefit for that is they have to be done for monitoring of previously diagnosed prostate cancer before you can bill Medicare, not have the patient pay for it. So when you test them, the initial tests, I think that one you can justify the MBS billing. Ironically, I think that subsequent tests, if it's ordered by a GP, even if their initial PSA is slightly elevated, should not be bulk billed or should not be Medicare billed. In fact, the patients often have to pay for that, which is ironic given that the recommendations now are that you have to test it twice within 3 months. So there is some controversy there, and I think it's just a disconnect between what the Medicare billing rules are and what the GPs are actually doing, and what the recommendations actually are. But if you look at the strict recommendations from the GP guidebook, it says, well, don't test PSA. So so that again is another disconnect between PSA testing, who pays for it, how often you can do it.
Yeah. Any questions? Just check them in the chat or unmute yourself and you can ask away. I thought it was a really thorough, presentation on really primary care specific stuff. So I think it was probably already all covered. But let's we'll give it a few more minutes, see if anyone puts anything in the chat.
I think it's a discussion that we have a lot with those younger guys that come in wanting testing because someone they know has been in the family, and so I think that was really useful.
I think a lot of people, especially patients now, they're a lot more educated, and there's a lot of media coverage. They talk about prostate cancer testing. Prostate Cancer Foundation is very active now, just raising awareness for prostate cancer and PSA testing, because we know we've become good at diagnosis, at screening. We don't overtreat, and by testing you you do save lives. You treat them accordingly and you treat them appropriately. So yeah.
And I think one of your recommendations there was if you got a family history of prostate cancer, if their PSA is greater than 2 or between 2 and 3, you'd suggest a urology referral.
Yeah.
So I saw someone like that today. It was, their brother died at 48.
Yeah.
And they're now 60 and their PSA is above 2. And I'm like, oh, you should probably go see the urologist.
Yeah, I think so. Yeah. I mean, some people just look at the median PSA, and the median PSA for a 50-year gentleman is actually 1. So if their PSA is above that, they're technically above the median number. So keeping in mind that the PSA testing, that number really is just the ends of the bell curve on on the other side. So
yeah.
I think it'd be good to see the college bring their guidelines in guidance with current practice.
And I think a lot of GPs that I speak to as well, especially the ones that do a lot of mental health, do acknowledge that their personal practice differs a lot from what the GP guidelines say, and they've kept abreast of a lot of these recommendations themselves. So they do testing a lot more often, they do it a lot more prudently, and they know what the triggers are for further investigation. So yeah, absolutely.
Are the perineal biopsies done by yourself, or are they done by the radiologist?
No, we do them all ourselves. Yeah.
The urologist.
Yeah, the urologist does biopsy. So
are they guided?
Yeah. So there are transperineal biopsies. There's many ways you can guide them, and the way that most people do it is just by matching the MRI scan with the ultrasound guided picture. So it's what we call cognitive fusion, where the urologist uses his brain to visualize what it should look like. There are some people that will use an MRI and software to map the MRI picture onto the ultrasound, which then guides exactly where you put the needle into. Right. But subsequent studies have showed that doesn't significantly increase the effectiveness of it. So that equipment is it takes time to set up, costs money to bring in. So so we just do guided MRI guided cognitive biopsies, fusion biopsies. Yeah.
The amazing cognition of the urologist.
That's right. One of the few things you have to think about. Yes, that's it. Yeah.
All right. Well, look, thanks so much for joining us, everyone. Thanks so much, Diwei. That was perfect. Yeah. Really appreciate your time again. I'm sure we'll get you back again.